Hey team, it's Good to Know Wednesday. Let's recap our knowledge of the intracranial pressure or ICP. ICP is the pressure within the cranium of the skull. When the cerebral autoregulation is intact, the ICP is kept between 5 to 15 millimeters of mercury for an adult. The Monroe-Kelly doctrines describe the relationship between cerebroperfusion pressure, contents of the cranium, and intracranial pressure, hypothesizing that due to cranium's rigid nature, an increase in any volume of the intracranial components should cause a reciprocal decrease in either one or both of the remaining two components. For example, a brain tumor increases the amount of brain matter within the skull. To maintain equal volume in the skull and prevent a rise in pressure, the body moves the cerebrospinal fluid down the spinal canal, thereby decreasing the CSF volume. If this fails to restore equilibrium, blood is also shunted out of the brain. The body can compensate for up to 100 mL of volume. Beyond that, the ICP will rise. As the brain tumor increases in size, the body will enter a decompensated state, whereby a small increase in intracranial volume can lead to sharp rises in ICP. If the pressure becomes very high, the brain matter is pushed through the foramen of Monroe, pressing on the brainstem, which is the area essential for breathing and neurological functions. And without immediate pressure-relieving intervention, this can be fatal. Other causes of high ICPs are hydrocephalus, traumatic brain injury, hemorrhage, infections, or other vascular abnormalities like aneurysms. In ICU, we monitor and measure ICP through EVDs, which also allows CSF drainage, or a Codman ICP monitor. Rarely, a decompressive craniotomy is performed to allow the swollen brain to expand outwardly. When the patient requires ICP monitoring, it is essential for our nursing interventions to prevent further rise in ICP. Remember, a sustained ICP of greater than 20 is associated with ischemic brain injury. So let's do the following. Patient positioning. If not contraindicated, patients with high ICP should be nursed in the head-up position in a 30 to 45 degree angle, with the head and body neutral to each other. This will decrease ICP by displacing the CSF and increasing venous outflow. Clustering of care. To prevent overstimulation of the patient, it is recommended to perform activities such as patient turning, bed bath, mouth care, and eye care all at the same time. If the ICP is continuously high, pressure area care should be limited as the priority is the patient's brain. Therapeutic normothermia. We all know that fever increases cerebral metabolic rate and oxygen consumption. Active cooling may be necessary, but ice and cooling devices can cause shivering, which increases ICP. Query the need for muscle relaxants if the patient starts shivering. Blood pressure management. Patients with a severe brain injury often present with an abnormal blood pressure. We should maintain a CPP greater than 60 or as per plan to prevent secondary injury like ischemia from hypoperfusion or increased edema from hyperperfusion. Blood sugar control. Hypoglycemia is bad in the severe brain-injured patient. The brain is an obligate glucose consumer and needs sugar to function. Carbon dioxide regulation. CO2 regulation is important in controlling ICP. Hypercapnia influences cerebral vasodilation, which increases intracranial blood volume, therefore increasing ICP, whilst hypocapnia vasoconstricts blood vessels and might lead to hypoperfusion, which will eventually cause cerebral ischemia and infarction. That's all for now. Paalam!